Chapter 16 Abnormal Behavior. In this chapter, summary. What is the first thing that comes to mind when you think about psychology? Before you took a psychology course, is probably mental health, especially abnormal behavior. Actually, 90% of what psychologists study is about normal behavior. People in good mental health have flexible beliefs, perceptions linked to an external stimulus, logical, coherent, goal-directed thoughts, a full range of emotions, and engage readily in normal verbal communication and motor acts. As president of the American Psychological Association, Martin Seligman promoted the positive psychology movement, an emphasis on the study of human strengths, fulfillment, and optimal living to help us improve our lives. Although this movement is gaining in strength and popularity, mental health professionals are still needed to help people suffering and psychological problems. This chapter looks at definitions, causes, and types of psychological disorders. Defining abnormal behavior. Defining abnormal behavior and showing how it is different from normal behavior is difficult and controversial. A common definition of abnormal behavior is behavior that is personally disturbing or disabling, or culturally so deviant that others judge it as maladaptive, inappropriate, or unjustifiable. Atypical or deviant means that, statistically, the behavior is rare and has a very low probability of occurring. Legally, insanity is an ability to determine right from wrong. Insanity is a rarely used defense plea in criminal cases because a finding of insanity results in commitment to a detention facility of individuals who are a threat to themselves or to the community. Psychiatrist Thomas Szasz sees classification of mental illness as reason to justify political repression, an extreme position that causes us to examine assumptions about what's normal and what isn't. David Rosenhan of Stanford University demonstrated that ideas of normality and abnormality are not as clear and accurate as people think. He and colleagues faked a single symptom of hearing voices to gain admission to mental hospitals in 5 states. They abandoned the symptom once admitted. They found hospitalization to be dehumanizing. Admitted with the diagnosis of paranoid schizophrenia, they were discharged with the diagnosis of paranoid schizophrenia in remission, under control. Causes of abnormal behavior. What causes abnormal behavior? Each perspective of psychology assigns different reasons. The psychoanalytic, psychodynamic perspective believes abnormal behavior results from internal, unresolved conflict in the unconscious stemming from childhood traumas. The behavioral approach says abnormal behavior consists of maladaptive responses learned through reinforcement of the wrong kind of behavior. Humanists believe abnormal behavior results from conditions of worth society places upon the individual, which cause a poor self-concept. Since behavior is influenced by how we perceive the world, the cognitive approach sees abnormal behavior as coming from irrational and illogical perceptions and belief systems. Evolutionary psychologists consider mental disorders as harmful evolutionary dysfunctions that occur when evolved psychological mechanisms do not perform their naturally selected functions effectively. The biological approach explains abnormal behavior as the result of neurochemical and/or hormonal imbalances, genetic predispositions, and structural damage to brain parts, or faulty processing of information by the brain. Finally, the modern biopsychosocial model considers that biological influences such as evolution, genes, brain structure, and biochemistry, psychological influences such as stress, trauma, learned helplessness, mood-related perceptions and memories, and social cultural influences such as roles, expectations, and definitions of normality and disorder all interact. The medical model. Abnormal behavior is often talked about as mental illness. The medical model looks at abnormal behavior as a disease, using terms such as psychopathology, which is the study of the origin, development, and manifestations of mental or behavioral disorders. Etiology, which is the apparent cause and development of an illness. And prognosis, which forecasts the probable course of an illness. The American Psychiatric Association used a medical model for the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, published in 2013 that classifies psychological disorders by their symptoms. This guidebook for mental health professionals lists diagnostic criteria for 22 major categories of mental disorders, subdivided into hundreds of disorders. DSM-5 enables mental health professionals to communicate information about individuals who suffer from abnormalities and helps them decide how to treat an individual. DSM-5 classifications have been used by special education teachers and school psychologists in preparation of individualized education programs, IEPs, required for classified students in schools, and by psychologists, psychiatrists, and other mental health workers for health benefit reimbursement by medical insurance companies. As of October 2014, healthcare providers are required to use diagnostic code sets from the World Health Organization's International Classification of Disease and Related Health Problems, ICD-10. The publishers of this book have created the Blue Book, the ICD-10 classification of mental and behavioral disorders, clinical descriptions, and diagnostic guidelines, with crosswalks to DSM-5. Essentially, DSM-5 and ICD-10 guide medical diagnosis and define who is eligible for coverage of medications, treatments, and special services. Criticisms of the use of these documents include that people who don't need diagnosis and treatment will get it. That labeling is dislabeling, whereby diagnostic labels are applied to the whole person. Example, John's a schizophrenic, rather than used to mean the individual is suffering from a particular disorder, and that people who need services will not get them. Types of disorders. The main DSM-5 categories of mental disorders are 1. Neurodevelopmental disorders, 2. Schizophrenia spectrum and other psychotic disorders, 3. Bipolar and related disorders, 4. Depressive disorders, 5. Anxiety disorders, 6. Obsessive-compulsive and related disorders, 7. Trauma and stressor-related disorders, 8. Dissociative disorders, 9. Somatic symptom and related disorders, 10. Feeding and eating disorders, 11. Elimination disorders, 12. Sleep-wake disorders, 13. Sexual dysfunctions, 14. Gender dysphoria, 15. Disruptive impulse control and conduct disorders, 17. Neurocognitive disorders, 18. Personality disorders, 19. Paraphilic disorders, 20. Other mental disorders, 21. Medication-induced movement disorders and other adverse effects of medication, 22. Other conditions that may be the focus of clinical attention. In an abnormal psychology or psychological disorders course, you might study all of these disorders, but introductory psychology students typically study selected disorders in addition to the eating disorders, sleep disorders, and substance-related disorders you've already encountered. These include anxiety disorders, obsessive-compulsive disorders, trauma and stressor-related disorders, somatic symptom disorders, dissociative disorders, depressive disorders, bipolar disorders, schizophrenia, personality disorders, neurodevelopmental disorders, and neurocognitive disorders. Anxiety disorders. Anxiety is the primary symptom or the primary cause of other symptoms for all anxiety disorders. Anxiety is a feeling of impending doom or disaster from a specific or unknown source that is characterized by mood symptoms of tension, agitation, and apprehension, bodily symptoms of sweating, muscular tension, and increased heart rate and blood pressure, as well as cognitive symptoms of worry, rumination, and distractibility. Anxiety disorders include panic disorder, generalized anxiety disorder, phobias, obsessive compulsive disorder, and post-traumatic stress disorder. Panic disorder is the diagnosis when an individual experiences repeated attacks of intense anxiety along with severe chest pain, tightness of muscles, choking, sweating, or other acute symptoms. These symptoms can last anywhere from a few minutes to a couple of hours. Panic attacks have no apparent trigger and can happen at any time. Since these are statistically rare, having perhaps 3 of these in a 6-month period of time would be cause for alarm. Generalized anxiety disorder is similar to a panic disorder. Symptoms must occur for at least 6 months and include chronic anxiety not associated with any specific situation or object. The person who frequently has trouble sleeping, is hypervigilant and tense, has difficulty concentrating, and can be irritable much of the time. Panic disorder has acute symptoms short in duration, whereas generalized anxiety disorder has less intense symptoms for a longer period of time. Phobias are intense, irrational fear responses to specific stimuli. Nearly 5% of the population suffers from some mild form of phobic disorder. A fear turns into a phobia when it provokes a compelling, irrational desire to avoid a dreaded situation or object, disrupting the person's daily life. Common phobias include agoraphobia, fear of being out in public, acrophobia, fear of heights, claustrophobia, fear of enclosed spaces, and zoophobia, fear of animals such as snakes, mice, rats, spiders, dogs, and cats. Obsessive compulsive and related disorders. Obsessive compulsive disorder, OCD, is a compound disorder of thought and behavior. Obsessions are persistent, intrusive, and unwanted thoughts that an individual cannot get out of his or her mind. Obsessions are different from worries. They generally involve a unique topic, such as dirt or contamination, death or aggression, are often repugnant, and are seen as uncontrollable. If a person were frequently bothered by thoughts of wanting to harm others, this would be called an obsession. Obsessions are often accompanied by compulsions, ritualistic behaviors performed repeatedly, which the person does to reduce the tension created by the obsession. Common compulsions include hand washing, counting, checking, and touching. Hoarding disorder is characterized by persistent difficulty discarding or parting with possessions due to a perceived need to save the items and distress parting with them. Trauma and stressor-related disorders. Post-traumatic stress disorder, PTSD, is a result of some trauma experienced, natural disaster, war, violent crime, by the victim. Victims re-experience a traumatic event in nightmares about the event, or flashbacks in which the individual relives the event and behaves as if he or she is experiencing it at that moment. Victims may also experience reduced involvement with the external world, and general arousal characterized by hyperalertness, guilt, and difficulty concentrating. The behavioral perspective says that anxiety responses associated with anxiety, obsessive compulsive, and post-traumatic stress disorders are acquired through classical conditioning and maintained through operant conditioning. The cognitive perspective attributes anxiety responses of anxiety, obsessive compulsive, trauma, and stress-related disorders to misinterpretation of harmless situations as threatening, focusing excessive attention on perceived threats, and selectively recalling threatening information. The biological perspective attributes anxiety responses, at least partly, to neurotransmitter imbalances. Generalized anxiety disorder, often treated with benzodiazepines, Valium, Xanax, is associated with too little availability of the inhibitory neurotransmitter GABA in some neural circuits, While obsessive compulsive disorder and panic disorder, often treated with antidepressants, Prozac, Paxil, Zoloft, are associated with low levels of serotonin. The evolutionary perspective attributes the presence of anxiety to natural selection for enhanced vigilance that operates ineffectively in the absence of real threats. Somatic symptom and related disorders. According to DSM-5, somatic symptom disorders are characterized by psychiatric symptoms associated with physical complaints. People with these disorders are primarily seen in medical settings where patients/clients complain of physical symptoms such as lumps, lightheadedness, pain, paralysis, blindness, or deafness, and are experiencing anxiety or maladaptive thoughts, feelings, and behaviors. The terms hypochondriasis and hypochondria are no longer used. Somatic symptom disorder, SSD, is characterized by physical symptoms including pain and high anxiety in these individuals about having a disease. Patients need to have complained about, taken medication for, changed lifestyle because of, or seen a physician about the symptoms and experience anxiety that has interfered with carrying on normal activities for 6 months. Illness anxiety disorder, IAD, is characterized by a preoccupation with a serious medical or health condition with either no or mild physical somatic symptoms, such as nausea or dizziness, that has persisted for 6 months. A woman who was preoccupied with a callus on her finger thought the lump could be cancer, although several doctors told her it was not. She kept thinking that she was going to die from it, and she could not get that off her mind. She was diagnosed with IAD. Conversion disorder, functional neurologic symptom disorder, is characterized by loss of some bodily function, such as becoming blind, deaf, or paralyzed, without physical damage to the affected organs or their neural connections as assessed by neurological examination. It is often marked by indifference and quick acceptance on the part of the patient. The symptoms usually last as long as anxiety is present. Psychoanalyst Sigmund Freud attributed somatic symptom disorders to bottled up emotional energy that is transformed into physical symptoms. Behaviorists explain that operant responses are learned and maintained because they result in rewards. Cognitive behaviorists continue that the rewards enable individuals with somatoform symptom disorders to avoid some unpleasant or threatening situation, provide an explanation or justification for failure, or attract concern, sympathy, and care. Social cognitive theorists think that individuals with somatoform symptom disorders focus too much attention on their internal physiological experiences, amplifying their bodily sensations, and forming disastrous conclusions about minor complaints. Dissociative disorders. Dissociative disorders are psychological disorders that involve a sudden loss of memory, amnesia, or change in identity. If extremely stressed, an individual can experience separation of conscious awareness from previous memories and thoughts. Dissociative disorders include dissociative amnesia and dissociative identity disorder. Dissociative amnesia is a loss of memory for a traumatic event or period of time that is too painful for an individual to remember. The person holds steadfast to the fact that he or she has no memory of the event and becomes upset when others try to stimulate recall. In time, parts of the memory may begin to reappear. A woman whose baby has died in childbirth may block out that memory and perhaps the entire period of her pregnancy. When more emotionally able to handle this information, the woman may gradually come to remember it. Dissociative fugue is a subtype of dissociative amnesia. Dissociative fugue is a memory loss for anything having to do with personal memory, accompanied by flight from the person's home, after which the person establishes a new identity. All skills and basic knowledge are still intact. The cause of fugue is often abundant stress or an immediate danger of some news coming out that would prove embarrassing to the individual. Dissociative identity disorder, DID, formerly called multiple personality disorder, is diagnosed when two or more distinct personalities are present within the same individual. Although extremely unusual, it is most common in people who have been a victim of physical or sexual abuse when very young. Amnesia is involved when alternate personalities take over. Missing time is one of the clues to this diagnosis. Each alternate personality has its own memories, behaviors, and relationships. It might have different prescriptions, allergies, and other physical symptoms. Although there has been some interesting work done by the National Institute for Mental Health that lends credibility to this diagnosis, many professionals are still skeptical about it. Psychoanalysts explain dissociative disorders as repression of anxiety and/or trauma caused by such disturbances of home life as beatings, rejection from parents, or sexual abuse. Many social learning theorists are skeptical about DID and think that individuals displaying the disorder are role-playing. They question why dissociative identity disorder, and also known as multiple personality, has become so much more prevalent since publication of books and production of films dealing with the disorder, and why different personalities pop out, in contrast to years ago when alternate personalities emerged very slowly. Depressive disorders. Depressive disorders are psychological disorders characterized by extremely sad mood and lack of energy that colors the individual's entire emotional state and disrupts the person's normal ability to function in daily life. Most people with depressive disorders are treated at least in part by drugs, suggesting a biological etiology or cause. The prevalence of depression has been increasing, affecting at least twice as many women as men. Because it occurs so often, depression has been called the common cold of psychological disorders. Major depressive disorder, single and recurrent episodes, involve intense, depressed moods, reduced interest or pleasure in activities, loss of energy, and problems in making decisions for a minimum of 2 weeks. The individual feels sad, hopeless, discouraged, down, and frequently isolated, rejected, and unloved. In addition to this sadness, there are a series of changes in eating, sleeping, and motor activity, and a lack of pleasure in activities that usually caused pleasure in the past. Cognitive symptoms include low self-esteem, pessimism, reduced motivation, generalization of negative attitudes, exaggeration of seriousness of problems, and slowed thought processes. Suicidal thoughts, inappropriate guilt, and other faulty beliefs may also be present. Depression with seasonal pattern, also known as seasonal affective disorder, SAD, is a subtype of depression that recurs, usually during the winter months in the northern latitudes. Patients often respond to regular exposure to artificial bright light sources. One hypothesis as to why this happens is that shorter periods of and less direct sunlight during winter disturbs both mood and sleep-wake cycles, bringing on the depression. Premenstrual dysphoric disorder may be an unfamiliar name, but its symptoms are probably more familiar to you if you know a woman who is between menarche and menopause and tells you to excuse her behavior because she is premenstrual. Symptoms include at least 5 of the following most months in the day before a woman starts her period, menses. Marked affective lability, examples, mood swings, feeling suddenly sad or tearful, or increased sensitivity to rejection. Marked irritability or anger, or increased interpersonal conflicts. Markedly depressed mood, feeling of hopelessness, or self-deprecating thoughts. Marked anxiety, tension, feelings of being keyed up or on edge. Decreased interest in usual activities, subjective sense of difficulty in concentration, lethargy, getting tired easily, or marked lack of energy, marked change in appetite, overeating, or specific food cravings, sleeping too much or insomnia, a subjective sense of being overwhelmed or out of control, and other physical symptoms such as breast tenderness or swelling, joint or muscle pain, a sensation of bloating, or weight gain. Biological psychologists have evidence from family studies, including twin studies, that there is a genetic component involved in depressive, bipolar, and related disorders. Too much of the neurotransmitter norepinephrine is available during mania. Too little of norepinephrine or serotonin during depression. Prozac, Zoloft, or Paxil increase availability of serotonin by blocking reuptake. PET or fMRI scans reveal lowered brain energy consumption in individuals with depression, especially in the left frontal lobe, associated with positive emotions. And MRI and CAT scans show abnormal shrinkage of frontal lobes in long-term severely depressed patients. Psychoanalysts attribute depression to early loss of or rejection by a parent, resulting in depression when the individual experiences personal losses later in life and turns angry inside. Behaviorists say that depressed people elicit negative reactions from others, resulting in maintenance of depressed behaviors. The social cognitive behavioral perspective holds that self-defeating beliefs may arise from learned helplessness, influence biochemical events, fueling depression. Learned helplessness is the feeling of futility and passive resignation that results from inability to avoid repeated aversive events. According to psychologist Martin Seligman, a negative explanatory style puts an individual at risk for depression when bad events occur. When bad events happen, people with a negative, pessimistic explanatory style think the bad events will last forever, affect everything they do, and are all their fault. They give stable, global, internal explanations. Cognitive viewpoints include Aaron Beck's theory, cognitive triad, that depressed individuals have a negative view of themselves, their circumstances, and their future possibilities, and that they generalize from negative events. And Susan Nolan Hoeksema's rumination theory that depressed people who go over and over the negative event in their minds are prone to more intense depression than those who distract themselves. Bipolar and related disorders. Bipolar disorder is characterized by mood swings alternating between periods of major depression and mania, the two poles of emotions. Symptoms of the manic state include an inflated ego, little need for sleep, excessive talking, and impulsivity. Rapid cycling is usually characterized by short periods of mania, followed almost immediately by deep depression, usually of longer duration. Newer drug treatments, including lithium carbonate, have proved successful in bringing symptoms under control for many sufferers. Schizophrenia spectrum and other psychotic disorders. Schizophrenia spectrum and other psychotic disorders are a diverse group of disorders that includes disorders also included in other groups, such as schizotypal personality disorder. Psychosis, reality distortion, evidenced by highly disordered thought processes, distinguishes the disorders in this classification. The most common disorder in the group is schizophrenia. In addition, in DSM-5 is catatonia. Schizophrenia is characterized by symptoms such as hallucinations, delusions, disorganized thought, disorganized or abnormal motor behavior, and negative symptoms. About 1% of people in the world have this disorder. Because one cause of schizophrenia is an excess of dopamine, antipsychotic drugs are effective in treating some symptoms in about 50% of patients. A positive symptom of schizophrenia isn't something that is good, but a behavioral excess or peculiarity rather than an absence. Delusions and hallucinations, two frequent signs of schizophrenia, are both positive symptoms. Delusions are fixed beliefs that are maintained even when compelling evidence to the contrary is presented. Hallucinations are false sensory perceptions, such as the experience of seeing, hearing, or otherwise perceiving something that is not present. Lack of emotion, sometimes called flat affect, social withdrawal, apathy, inattention, and lack of communication are examples of negative symptoms of schizophrenia. Some people with schizophrenia may make no sense when talking and act in a bizarre way that is inappropriate for a situation, such as laughing or acting silly during a solemn ceremony. Other people with schizophrenia evidence paranoid symptoms characterized by delusions of grandeur, persecution, and reference. For example, people with paranoid symptoms often think that ordinary events, objects, or behaviors of others have unusual and particular meaning for them. Delusions of reference. They often misinterpret occurrences as directly relevant to them, such as lightning being a signal from God. They frequently believe that such attention is because of their specialness and that they are world leaders, delusions of grandeur. They also think that others are so threatened that these other people plot against them, delusions of persecution. Suffering delusions of persecution, people are fearful and can be a danger as they attempt to defend themselves against their imagined enemies. Schizophrenia with catatonic symptoms are characterized by disordered movement patterns, sometimes immobile stupor, or frenzied and excited behaviors. Biological psychologists attribute some positive symptoms of schizophrenia, such as hallucinations and delusions, to excessively high levels of the neurotransmitter dopamine, and some negative symptoms, such as lack of emotion and social withdrawal, to lack of the neurotransmitter glutamate. Brain scans show abnormalities in numerous brain regions of individuals with schizophrenia. These abnormalities may result from teratogens such as viruses or genetic predispositions. The diathesis stress model holds that people predisposed to schizophrenia are more vulnerable to stressors than other people. Thus, only people who are both predisposed and also stressed are likely to develop schizophrenia. Psychoanalysts attribute schizophrenia to fixation at the oral stage and a weak ego. Behaviorists assume that schizophrenia results from reinforcement of bizarre behavior. Humanists think schizophrenia is caused by lack of congruence between the public self and actual self. Schizophrenia is not split personality. People with schizophrenia experience a split with reality. People with dissociative identity disorders show two or more personalities. Catatonia is characterized by the presence of behavior and movement traits. Movement traits can include immobility, not reacting to external stimuli, stupor, posturing, rigidity, staring, and grimacing. Waxy flexibility is a motor symptom demonstrated when someone else moves the arm or leg of a patient, remaining in one position like a statue, and the patient keeps the arm or leg in the new position, maintaining a posture that would normally be impossible to hold by others. Behavioral interactions with others can include unresponsiveness, mutism, negativism, meaningless repetition of words or sounds, echolalia, and withdrawal. Diminished activity may or may not cycle with short periods of agitation and frenzied, purposeless movements such as neck twitches, arm jerks, or even running and kicking. In the excited state, patients can evidence impulsivity or combativeness. Catatonic excitement can be very dangerous. Personality disorders. People with personality disorders have long-standing maladaptive thought and behavior patterns that are troublesome to others, harmful or illegal. Although these patterns impair people's social functioning, individuals do not experience anxiety, depression, or delusions. DSM-5 groups personality disorders into three clusters: odd eccentric, including paranoid, schizoid, schizotypal; dramatic, emotionally problematic, including histrionic, narcissistic, borderline, and antisocial; and chronic fearfulness avoidant, including avoidant, dependent, and obsessive-compulsive. Odd eccentric disorders. Paranoid. Pervasive, unwarranted suspiciousness and mistrust. Overly sensitive, often envious, more common in males. Schizoid. Poor capacity for forming social relationships. Shy, withdrawn behavior. Considered cold, more common in males. Schizotypal. Odd thinking, often suspicious and hostile. Dramatic, emotionally problematic disorders. Histrionic. Excessively dramatic, seeking attention and tending to overreact. Egocentric, more common in females. Narcissistic. unrealistically self-important, manipulative, lacking empathy, expects special treatment, can't take criticism, more common in males. Borderline, emotionally unstable, impulsive, unpredictable, irritable, prone to boredom, more common in females. Antisocial, used to be called sociopaths or psychopaths, violate other people's rights without guilt or remorse, manipulative, exploitive, self-indulgent, irresponsible, can be charming, commit disproportionate number of violent crimes, more common in males. Chronic fearfulness, avoidant disorders. Avoidant, excessively sensitive to potential rejection, humiliation, desires acceptance but is socially withdrawn. Dependent, excessively lacking in self-confidence, subordinates own needs, allows others to make all decisions, more common in females. Obsessive compulsive, usually preoccupied with rules, schedules, details, extremely conventional, serious, emotionally insensitive. Neurodevelopmental disorders. Disorders of infancy, childhood, and adolescence include intellectual disability, attention deficit hyperactivity disorder, and autism spectrum disorder. Attention deficit hyperactivity disorder, ADHD, is a common childhood disorder that affects up to 9% of children between 13 to 19 years old. Boys are 4 times more at risk than girls. Symptoms include difficulty paying attention and staying focused, difficulty controlling behavior, and hyperactivity to a greater degree than most other children of the same age over a period of at least 6 months. Symptoms of inattention are evidenced when a child is easily distracted, misses details, forgets things, switches from one activity to another, gets bored with a task after only a few minutes, does not complete tasks, loses things needed to complete tasks, does not listen when spoken to, daydreams, becomes easily confused, and has difficulty processing information as quickly and accurately as others. A child who has symptoms of impulsivity may be very impatient, blurt out comments inappropriately, act out without considering consequences, interrupt conversations or the activities of others, and have difficulty waiting for things they want or waiting to take a turn. A child showing symptoms of hyperactivity may fidget and squirm, talk incessantly, move around touching or playing with everything in sight, have trouble sitting still, and have difficulty doing activities silently. 3 subtypes of ADHD are predominantly hyperactive impulsive, predominantly inattentive, and combined hyperactive, impulsive, and inattentive. Most children with ADHD have the combined type. The inattentive and inappropriate behaviors of people with ADHD often lead to personal, social, and academic or work problems. Autism spectrum disorder is a neurological disorder first diagnosed in childhood. Diagnosis is based on 3 primary symptoms: lack of responsiveness to other people, impairment in verbal and nonverbal communications, and very limited activities and interests. Children with autism spectrum disorder engage in repetitive behaviors such as hand flapping or repeating sounds or phrases. About 1 in 88 children is diagnosed with autism. Autism spectrum disorder is 3 to 4 times more common in boys than girls. Organic/neurocognitive disorders. Changes in the brain can affect all aspects of behavior and mental processes. DSM-5 labels disorders characterized by a decline from a previous level of neurocognitive function as neurocognitive disorders, and ICD-10 labels them as organic disorders. Loss of function may involve complex attention, executive function, learning and memory, language, perceptual motor skills, and motor cognition. DSM-5 categorizes disorders as major or mild and may be linked to a specific disease or brain damage such as Alzheimer's disease, traumatic brain injury, HIV infection, and Parkinson's disease. All of these can result in dementia, the loss of mental abilities. Alzheimer's disease is a fatal degenerative disease in which brain neurons progressively die. Mild or major neurocognitive disorders due to Alzheimer's disease is characterized by loss of memory, reasoning, emotion, and control of bodily functions. Alzheimer's strikes 3% of the world's population by age 75. Delirium is characterized by impaired attention and lack of awareness of the environment. It may involve loss of recent memory or orientation, language disturbance such as rambled speech or mumbling, and perceptual disturbance. Associated features include change in the sleep-wake cycle, change in emotional states, and worsening of behavioral problems in the evening.